Good afternoon, everyone. My name is Singh, and on behalf of the National Coordinating Center for PHSR here at Lexington, Kentucky, I would like to welcome everyone to our PHSR Research in Progress webinar series. We are delighted to have with us today Dr. Simone Singh, who will be presenting her research on the variations in the cost of delivering public health services and analysis of local health departments in Florida. And also with us will be commenting on her research after her presentation is Dr. Patrick Burnett from Louisiana State University and Robert Vito from the Florida Department of Health, Brevard County. And before we get to our presentation, we'd just like to welcome those who are also joining us for the first time or who are not as familiar with this webinar series. It is a series of webinars that are presenting the work and research of our 2013 to 2014 pre- and postdoctoral research awardees. These are one-year mentored research awards that are supported and funded by the Robert Wood Johnson Foundation. And so we have here on our slide some of the past presentations. And for those who are interested, these can be accessed from the National Coordinating website. So I'd like to introduce our speaker for today, Dr. Simone Singh, who is an assistant professor of health management and policy at the University of Michigan. Dr. Singh's research agenda focuses on improving our understanding of accounting practices and financial management strategies of both healthcare and public health organizations. Most recently, the focus of her work has been on examining differences in productivity and efficiency in service delivery across local health departments. So Dr. Singh, we are delighted to have you with us, and we look forward to your presentation. Simone, you have the floor.
Thank you, CB, and good afternoon, everybody. I'm so pleased today to be here and present findings from my research on variations in the cost of delivering public health services using data that Patrick Burnett and I were able to obtain from Florida. So before I get started, I'd like to acknowledge Dr. Patrick Burnett. He was my mentor and co-author on this study, and he, together with folks in Florida, were able to get me access to the data I needed for this research. And I'd also like to thank the Robert Wood Johnson Foundation for funding, and as CB mentioned, I was one of the postdoctoral scholars that was funded in last year's cohort. So just to give a bit of context for this work, in 2012, the Institute of Medicine published a report entitled For the Public's Health, Investing in a Healthier Future. And in that report, the IOM recommended, among many other things, substantial increases in federal funding for public health so that public health agencies really have the resources they need to invest in healthier communities. And the prevalent hypothesis underlying this call for action was that increased financial resources would allow public health agencies to improve their internal processes and performance, which would then in turn allow them to better serve their communities and improve population health. And so you can see here a graph from an article published by Maya Davis and Mace. And in this model, you can see that there's one key element of process and performance of an LHD, which is cost and efficiency of service provision. So for the past 2 years or so, I've been involved in a number of research projects that aim to better understand the cost of public health service provision, especially at the local level, and also studying the factors that drive the cost of service provision. And eventually, myself and others in the field, I think, are very interested in connecting, cost and efficiency aspects to improve population health outcomes. So when I first began to conduct a research in this area, I come from the healthcare side, so public health was new to me then. I was surprised to find that there's actually very little that's known about the costs that health departments incur in providing public health services. And there are, likely a number of reasons for why this may be the case. Two of them are listed here. One is that health departments often have limited capacity or expertise to collect cost information, which would then form the basis for any research study on this topic. Moreover, there is a lack of a standard chart of accounts, as many of you may know, and this lack of a standard chart of accounts complicates cost comparisons and benchmarking across health departments. So even when we have cost information, we cannot easily compare it across different LHDs and across different states. So the good news is that there are now a number of efforts underway to address these issues, and examples include the Depts studies that some of you may be involved in. And also there are efforts now at the national level to develop a standard chart of accounts, so hopefully in the future we'll have better cost information. Without really understanding what's going on in terms of cost, public health policymakers lack some crucial information about the resources that health departments need and use when providing services. And as a public health practitioner, you're really flying blind when you're trying to make decisions about how to use financial resources to achieve the best possible outcomes if you don't know your cost structure. So the research questions that Patrick and I focused on for the purpose of this specific study were the following two. First, how much does it cost health departments to provide select core public health services, and what's the variation in cost across health departments? And then second, what factors drive health departments' costs of service provision, whereby we focused on the importance or the role of economies of scale and scope. So we chose 5 core public health services, and they are listed here: communicable disease surveillance and investigation, chronic disease prevention, food hygiene services, on-site sewage treatment and disposal services, and vital records services. And so we chose those services from, probably something like 50 or 60 services that they could choose. Those services because they represent some of the larger services that a health department usually engages in terms of both the total number of services provided and also the total expenditures incurred in providing these services. So that gets me to the data sources for this study. So data came from 3 sources. The most important source is the Florida Department of Health. So the Florida Department of Health collects on an annual basis expenditure information, number of services provided, number of clients served, and a number of other items from all health departments in Florida for each service line. So for each of the 5 services plus a number of others I just mentioned, we have expenditures, number of service, and number of clients. And then we complemented these data with information from the nature profile studies and the area resource file. And the sample for this study included all 67 Florida county health departments. So in Florida, each county has its own health department, and so each health department serves one county. And so we had 67 counties and 67 health departments for 2 years, 2008 and 2010. So in terms of how we measured costs, so we used 3 different approaches. The first was we looked at total cost. And total cost is just the total cost of providing a service in a given service line, which includes both direct components such as direct labor, supplies, etc., and also indirect components, which is more commonly known as overhead cost. We then also calculated the cost per service by dividing total cost into the number of services provided, and then cost per capita by looking at a total cost divided by the number of clients served. So we have 3 different cost measures that we used for this work. So you can see here in this in this table that total cost and the cost per service for the 5 services that we looked at varied quite substantially across service lines and also across health departments. So let me give you an example. In 2010, the average Florida Health Department spent around $108,000 on food hygiene services. You can see the standard deviation is quite large, so there was a lot of variation across health departments in Florida. The cost per service also ranged quite a bit. So the median cost was $104 for a food hygiene service. But you can see that the 25% of LHDs with the lowest cost spent only about $74 or even less on providing such a service versus the $133 that was spent by the 25% of the most costly health departments. And so when you compare that, you can see that the most costly health departments spent almost double compared to the least costly health departments. And you can also see a similar discrepancy, a similar variation for other services, for the other ones examined in the study. So when we saw these quite substantial variations in the cost of service provision, Patrick and I were interested in exploring a little bit more what drives some of this variation. And so as you may be aware of, many studies have looked into, spending and to some extent cost, and many factors have been hypothesized to contribute to variations in cost. And as economists, our focus for this specific study was on trying to understand better the role of economies of scale and economies of scope. So to provide a bit of background for folks not familiar with these theories, so theories of economies of scale suggest that the cost per unit decreases as more units are produced. So first, and this may be intuitive, if you have high fixed costs such as a lot of staff, higher fixed costs can be spread over more units as you produce more units, and thereby you can reduce your per unit cost. Second, if you have greater volumes, you can hire more specialized staff, and so each staff member can then work at the top of their license. So for example, a rural health department may not have adequate patient volume for both a prenatal nurse and a health educator. So if you use one person for both services, you have to pay that staff member at the higher job classification, even when that staff member performs duties of the other job. So as a result, if you are working with low volumes, your per unit cost can be quite high. Finally, and you can see this in the graph here, there can also be diseconomies of scale. So if your organization gets too large, right, if you produce output that's beyond the optimal, then things such as communication breakdowns, bureaucratic inertia, or other principal agent type problems can develop, and your average cost doesn't decrease anymore, but actually starts to increase again. And the graph again, shows this. So economies of scale happen in that sort of left part of the graph. As you move from Q to Q1 in terms of output, you can see that average cost on the y-axis goes down from C to C1. So if that happens, we speak of economies of scale. Okay, so let's move on to economies of scope. So the theory behind economies of scope is that the cost per unit decreases as more different services are produced. So scope economies may exist in a larger health department, for instance, if the health department can jointly produce a number of services and thereby reap the benefits of lower cost. On the other hand, if you are a small health department and you're required to provide a wide variety of services, scope diseconomies may be the result. And so the graph here again illustrates this concept. So on the top graph here shows a situation where there's no economies of scope. So if a firm wants to produce more service X1, they want to move over to the right on the x-axis, you can see that they have to reduce the provision of service or a product X2. The graph on the bottom shows a situation where there are economies of scope. You can see if a firm wants to produce more of service X1, they still have to reduce their production of service X2, but less so than in the case above. And so the shorter arrow indicates that there are economies of scope in this case. Okay, so let me talk a little bit about the multivariate model that we use for this manuscript or for this study. So we used a model that's commonly used in economics, which is a translog cost model. The key feature here is that the dependent variable, which is the cost variable, is not total cost, but is the logarithm of total cost. The reason for that is, as you can see in the graph, is that cost in public health and healthcare in general is often highly skewed. So taking the logarithm actually helps you come up with more of a normal distribution of cost. So this translog cost model then expresses the log of cost as a function of, in our case, economies of scale and scope, and a set of control variables that included agency, population, community characteristics. We performed cross-sectional analysis using ordinary least squares regression. We ran separate models for each of our 5 services or activities that I mentioned before. And then we, as I said, we used the log cost as the dependent variable. So let me provide a little bit more detail about how we measured economies of scale and scope in the study. So to model economies of scale, we included two indicators in our study. The first one was the total number of services provided, and the second one was the square of that total number of services provided. So the idea behind including the square of the number is that this quadratic term is used in economics to capture increasing or decreasing marginal effects. So in our model, economies of scale would be indicated by a positive coefficient on that first indicator on total number of services, because total cost increases as the number of services provided increases. Economies of scale would be indicated by a negative coefficient on that square term, because if there's a negative coefficient on that term, it means that total costs increase as volume increases, but they do so at a decreasing rate, which is exactly what economies of scale suggest. So to model economies of scope, we also calculated or computed a couple of indicators. We chose 6 categories of services that are commonly provided by health departments. They are listed here: clinical preventive, medical care, specialty, population-based, regulatory and licensing, and environmental health services. And so for each of these indicator variables, we calculate the proportion of services in each category that's provided by the health department itself versus by some other agency in the community or by, by some other stakeholder, or even not provided in the community at all. And maybe just to clarify, for economies of scope, the data came from the nature profile studies. And for those of you who are familiar with the nature profile studies, you probably know, how the profile survey asks about health department about whether they provide a certain service or not. And for economies of scale, we use the data that we had from the Florida Department of Health. So just maybe that helps people understand better what we did here. Okay, so let me show you some graphs. So here you can see the relationship between the number of services provided on the x-axis and total cost and cost per service on the y-axis. And this example is for on-site sewage treatment and disposal services in Florida. So you can see on the left that total cost increased as the number of services increased. Yet you can see, comparing the scatter plot to that line, you can see that the rate seems to slow a bit for larger volumes. If you then look at the graph on the right, which shows you cost per service on the y-axis, you can see that as the number of services increases, cost per service decreases, which indicates that economies of scale may indeed be present here in the production of this service. So the following table now presents some of our multivariate findings, and I'm only going to show you the coefficients on the scale and scope indicators, but we did include a range of other agency, population, and community characteristics in these regressions as well. So we control for a number of other factors. So you can see here we have 5 columns, and each column corresponds to the results of one of the key services that we looked at. So in terms of scale and scale of services provided, you can see here that with one exception, with the exception of chronic disease prevention services, there are positive coefficients on the total service indicator that we include in our models. So that shows that as the number of services increases, total cost increases, which is to be expected. You can also see that on in the second row, the services square term, you can see that there's a negative coefficient, and it's statistically significant for 4 of the 5 services that we studied. So you can see that while total costs increase, it looks like our model supports the idea that the rate at which they increase is decreasing as the volume increases. So in other words, per unit cost decreases as the volume of services increases, which is exactly what the presence of economies of scale would suggest. So if you look at the scope indicators, on the other hand, you can see that with one exception, there was really no coefficient that was statistically significantly different from 0. So the scope of service provision was not associated with any meaningful changes in LHC's cost of providing any one of these 5 services that we examined. And so you may be wondering sort of what this looks like if instead of using total cost as the dependent variable, we look at cost per service and cost per capita. And the answer is that the results are qualitatively very similar. So here I show the example of food hygiene services only, and so you can compare 3 different models: total cost in the first column, and then cost per service and cost per capita in the 2 columns on the right. And so you can see again that for scale of services, we have statistically significant results, so indicating that there seem to be economies of scale in the production of at least this specific service. And then again, looking at the scope of services, you see there's almost nothing that is statistically significant. So again, no matter which of these 3 specifications we chose, the results are quite similar. And these results are mirrored or are very similar to what we find for the other 4 categories or 4 activities that we looked at. I didn't include those here, but we did run all the different models, and we found very similar results. So it appears that our results are quite robust to the specification of the dependent variable. So to summarize our findings, our results support the existence of economies of scale in the production of key public health activities, although larger numbers of services was associated with a higher cost, total cost, cost per capita, and cost per service. That negative coefficient on the square term indicates that the cost actually increased less than proportionally, so indicating that there may be economies of scale here. We did not find any evidence of economies of scope, though, and there may be different reasons for why this is the case, and I'll discuss this a bit more. But basically, producing a greater range of services, as measured in terms of these indicators from the Nature Profile study, was not associated with lower costs for any of the 5 key services that we looked at. So let me provide a bit of discussion before wrapping up and then passing it over to Patrick and Robert for commentary. So to our knowledge, this study is among the first to systematically search for economies of scale and scope in the delivery of public health activities at the local level. And the findings here indicate that economies of scale may actually arise in the production of many core public health services. And to some of you, this may not be surprising. If you think about the fact that many public health services require a quite substantial level of fixed capacity and staffing, that results in high fixed costs. And so, as you increase volume, it's easier to spread these costs over a number of services, and so reduce your per unit cost. However, the presence of economies of scale in the delivery of public health has important implications for how public health should be organized, especially at the local level. So if you can increase the number of services provided in a certain area and reduce your cost per unit of service, that may free up resources that you may be able to use in other areas. And so evidence of economies of scale may inform discussion of local health district consolidation, regionalization, the provision of shared services, or other types of contracts and partnerships. So an individual health department may, for instance, provide food hygiene services for an entire region, but then they may decide to discontinue the direct provision of other services, let's say on-site sewage inspection, in favor of contracting these services from another LHD or from someone else in the region. And so taking a bit of a broader perspective beyond the health department, but thinking about them as a group, can actually help think about how an LHD may possibly achieve economies of scale. Of course, and all of us know this is obviously not a decision that can only be made based on financial analysis. Of course, there's a decrease in autonomy for an LHC. There are legal issues, and so of course there are many factors that need to be taken into account in these kinds of decisions. But certainly having an understanding of the cost may help in these discussions, or may inform these discussions. Our findings of scale economies, however, also pose some challenges, especially for smaller health departments. Higher cost per unit at lower volumes really means that a smaller health department may not be able to engage in the same level of public health activity, even if their budget or their staffing per capita is equal to that of a larger health department. And that's actually an important finding, or an important implication of these findings. Staffing decisions can be really challenging at low volumes. I mean, if you hire someone who's highly specialized, they may not be very efficient. But then again, if you have someone, they may be very efficient, but if you have someone who's very specialized, right, they can only perform limited functions. So you have to trade off here between paying a highly trained worker who's then overqualified for other tasks that they are assigned to do, or you use lower qualified workers who may then be less efficient. And so our findings certainly support some of the ongoing discussions of smaller health departments, that they may need to look more closely into partnerships, contracts, etc., if they really want to reduce the cost of providing services. The last point here, the breadth of service provision, we saw there was no association between our indicators and the cost of service provision. And these findings are actually encouraging, because if you think about your typical health department, right, many of these agencies are expected to provide a range of services. So it's often hard to limit what a health department can do, but there's legal requirements and there's mandates what they have to do. And so if there's at least no diseconomies of scope, right, that's a good thing, because at least from a financial perspective, the decision about the range of services offered can be more influenced by strategic considerations and, of course, by the legal requirements rather than by the cost considerations per se and only. So let me point out a couple of limitations of this work. As you can see, we use data from only one state, the state of Florida, and we only used 2 years, 2008 and 2010. So that certainly limits the generalizability of our findings to other states and other timeframes, especially as health departments across the country have experienced. There have been budget and staffing cuts in Florida as well, and so future research will be needed to see, whether the specific time frame we chose affected our findings. Moreover, we only looked at 5 services, or 5 service lines, maybe sort of a better way of characterizing these. And again, we don't know at this point whether our analysis and our findings apply to other commonly provided services, and how they may differ. And then finally, there are certainly a number of other factors that will affect variations in cost that we were unable to control for because of data limitations. And so 2 are listed here. One is that we really don't have any indication of the variation in types of services provided. So if you think about food hygiene services, this will include a number of different inspections, for instance, right? But an inspection is not an inspection, right? So different inspections use different amounts of resources, time, and money. So we don't have any ability in this study to control for any variation in sort of the types of services provided within a service line, or in what, from a healthcare perspective, you may think of in terms of the case mix. So we don't have any kind of control for that. And that may obviously well affect the variation in cost. We also didn't have good indicators of quality of services provided, and that's maybe even more critical. Trying to understand the link between cost and quality in public health, and sort of the effect of one on the other, I think, is something that future research really will need to look more into. So let me end with some implications for policy and practice. Certainly, having an in-depth understanding of their cost structure and what it costs them to provide services presents opportunities for health departments. They can better communicate to policymakers what they need in terms of resources. They can engage more thoughtfully in activities aimed at increasing efficiency of service provision, and they can also in that vein, make better decisions about partnerships, shared services, or other types of contracts to lower costs and increase the efficiency of their service provision. So if you're interested in more detail, there are two Frontiers articles that myself and Patrick Burnett have published using data from Florida. They're listed here on the slide. We also have another article or manuscript coming out in the PHSR special issue that's forthcoming, I think in early of 2015. So it'll be a special issue of the American Journal of Public Health. And this article will basically be exactly what I presented today, but provide more detail, more discussion. And then if you're interested more generally, I did conduct a systematic review of what's known about the link between public health spending and population health outcomes, and that review will be forthcoming next month in the American Journal of Preventive Medicine. So thank you very much, and I look forward to your comments later and to any questions you may have.
Thank you very much, Simone. I'd like to take this time first to introduce our two guest speakers who will be commenting on Simone's research. Our first guest speaker is Dr. Patrick Burnett, who's an associate professor at the Louisiana State University School of Public Health. Dr. Burnett's research focuses on public health, financial and operational performance, cost efficiency, hospital bond financing, consumer choice modeling, and healthcare provider efficiency. Patrick has authored numerous articles in academic texts and refereed journals. Our second guest speaker is Robert Zito, who is the financial administrator at the Florida Department of Health, Brevard County. He is also past president of the Florida Public Health Business Managers Association. Robert has over 15 years of experience as a business manager and financial manager in Florida County Health Departments, overseeing day-to-day financial and administrative operations and organizing capital expenditures and developing long-range strategic plans. So Patrick will first comment on Simone's research, and he'll be followed immediately after by Robert. So Patrick, you have the floor.
Okay, great. Let me just double check. You can hear me okay?
You're loud, coming loud.
This is not good. All right, let me take it off mute. No, this is a problem.
Patrick, this is Ann Kelly. We can hear you just fine. Just go ahead.
Thank you. Okay. Yeah. That's all I needed to know. All right. I wanted to extend my own thanks to the public health officials from Florida for facilitating the study, and to Simone Singh, who went way beyond her initial proposal on this project. This was supposed to be a small training project for her, and I should feel bad about encouraging her to go to do a lot more than was needed. And perhaps if I had a conscience, I would feel bad. This study is something that I've wanted to do for years. It's the kind of research that's going to help us make better resource allocation decisions, the kind of stuff that we need to do to get better population health outcomes. If you could kind of go backwards a few slides to the slide with the two graphs side by side. It sounds funny, but as an economist, it's those kind of pictures that I love. Because in there, it actually kind of shows something. Thank you, perfect. That slide is telling because it looks at, on the one on the right, you can see that the curve kind of goes down, but then it does level out at a point. And it's that leveling out point that is interesting, because while we did find economies of scale, we did find that after a point, it kind of levels out, which kind of says it seems like it might help to regionalize or get together to provide services in bulk. But beyond a certain area, you're probably big enough to get most of the economies that you're going to get. And it's that kind of stuff that I've been looking to do. And now, speaking of this kind of findings, what I'm going to do is I'm going to limit my comments to where I want to go with this line of research and reinforce some of the things that Simone had mentioned. Now, first, we only, as Simone had mentioned, we looked at only 5 services. There's about 50 separate service categories in Florida. And I would like, not just personally, I invite other people to help us to start looking at the efficiencies and effectiveness of all of those other services. Now, in order to balance resource use, we need that broad perspective of all services in order to make the best use of our resources. As Simone mentioned, we're kind of flying blind with a lot of these decisions, and what we're trying to do with this line of research is shed some light there. Now, one of the other things I'd like to see done with this line of research is to extend it to look at the economies of scope that Simone had mentioned. We tried to do some simple tests of economies of scope, but there are, and as Simone had mentioned, that would be, for example, looking for things like, does it pay to have an epidemiologist down the hall? In other words, specifically, does it make our chronic disease workers more efficient if they have an epidemiologist down the hall that they can go and ask questions of? Now, to do that kind of research, we need to do things in a more sophisticated manner. We do need to do things called data envelopment analysis or structural frontier analysis, which gets to be, and again, with all due respect to my colleagues on the phone, I know that there's people on this call who are even geekier than I am and could speak to those methods a lot better than I. But if we go down that line, it starts to move this conversation into a really technical area. So what I'd like to do is to bring the conversation back to reality and turn the commentary over to Bob Vito, who has actually has firsthand experience in this, and will hopefully manage to find a way of turning this all back into something practical for the practitioners on the line. Thanks.
Okay, well, thank you, Patrick. This is Bob Vito from sunny Florida, 88 degrees today. And thanks for reaching out to the field to involve those of us who are involved in day-to-day operations. I'm assuming y'all can hear me?
Yes, Bob, you're coming out loud and clear. Go ahead.
Thank you. We welcome research like this that helps us find ways to reduce our cost per unit of providing services without decreasing quality. Here in Florida, we have a statewide Department of Health that's centrally located in Tallahassee, our state capital, and each of our 67 counties have a branch of the state health department called county health departments, which is a little misleading since we are state agencies under the jurisdiction of the Department of Health. For each of the past 6 years, as I'm sure in other states, our state legislative funding for Department of Health has decreased year after year. And these cuts are also passed down to the county health departments where many services are actually delivered. And in addition to these budget cuts over the past year, our clinical services, which have been reimbursed at a robust Medicaid cost-based reimbursement rate the past 20 years, all transitioned to a statewide Medicaid HMO system that just reimburses us at the meager Medicaid fee-for-service. So we're seeing our Medicaid revenues this year decrease up to 60% from prior years. So we've had the double whammies of decreased funding and decreased billable revenues. And that's what makes these economies of scale studies valuable to us in the field while we're trying to cope with these ongoing budget cuts. And in the study, 5 programs were studied, and we would like to see more programs studied as well. This research went back to 2008 and 2010, which is when our 6-year trend of cost reductions took place. And we'd like to see it extended to 2012 and even 2014 to further validate the results that came out. And if we've seen, as these studies validate, that we do see the cost reductions when we start sharing services among other county health departments. It's not just theory, it's actually happening. In Florida, we have an active business managers association that's made up of the financial managers of each of the 67 county health departments. And we're grouped into 7 regions. And we do get together every month to share ideas of cutting costs and also to commiserate with each other. And we're at the point now where you just can't cut any more costs without destroying services. And cost reductions can only come from sharing services. And research like this really helps us make some intelligent choices as to which services can be shared and which ones cannot without losing quality. Now, how do you implement shared services? I just want to give two examples over the past 6 years, one that worked well and one that did not. Here's one that did not work well with human resources. Our county health departments have our own human resource department. And about 6 years ago, we were told by Tallahassee that we had to regionalize all the 67 county health department, HR departments into only 3 locations located across the state, and to share the costs of these 3 offices by cutting staff at each of the 67 county health departments to fund the 3 regional sites. There was a lot of resistance to this concept and a lot of fighting over about a 6-month time period. The end result was the idea was abandoned and it was never implemented. So the opportunities for cost sharing didn't happen, but why it didn't happen may be reflected in an actual success story, which is just the opposite. Also about 6 years ago, the Finance and Accounting Bureau in Tallahassee offered to have purchasing and accounts payable outsourced to them from any willing county health department without any cost to us in the field. Right away, 12 county health departments volunteered to participate, and that number is now over 20. So those county health departments were able to not rehire their purchasing and accounts payable staff when they retired or resigned, and to reduce their costs by having central office do those services at a better efficiency. We currently have a work group that took on regional billing. We have a pilot site that now does billing for 2 health departments, and we plan to expand that. It's just too difficult to hire and train now that we migrated to Medicaid fee-for-service, coders, ICD-9 coding, and ICD-10. In other areas, we've also started sharing labor relations specialists. We're sharing attorneys now. We're sharing regional tuberculosis nurses and regional indoor air quality specialists rather than having one inside each of our own county health departments. We see that cost per units do decrease and the expertise of performing these specialized tasks increases. So we're now more open-minded towards sharing services with other county health departments rather than doing everything in-house. We see that we are reaching out more to other county health departments to identify what services they're doing well because they have better resources, better knowledge, better skills. And as I said before, as staff resigns and retires, we used to automatically look to replace that position, but now that our costs have been cut and our reimbursement is down with Medicaid, we are actively looking to join in with other county health departments who already have an infrastructure in place that can be added to. As we started our Business Manager Association year this year, we have a new list of shared services that we're looking to implement, especially administrative services, clinical services, environmental health services. What's important is that these initiatives are being driven by the county health departments in the field. They're not being forced to us by the central office in Tallahassee. And this approach is working. We appreciate their empowering us to come up with our own solutions. And we appreciate the research that's done, such as what was presented earlier today, to help guide us in the field to attain these results. So the conclusion, we'd like to see more studies studying this topic, consolidating public health services, measuring the cost savings and the quality. And we want to see more studying of the links between outcomes, services, and operational consolidations. And at this point, I just want to emphasize, we need to take advantage of these new ideas and new opportunities to consolidate other services as a result of further research like this. So I'll stop now and see if there's any questions or comments.
Thank you, Bob. Thank you, Patrick, for your comments. Before we open the floor and the lines to your questions, I'd like to give Simone a chance to respond to the comments. Simone?
No, thank you, Patrick and Robert. Those were excellent comments, and I think, especially thank you to Robert. It's always, great to hear how this really actually, helps potentially, actual health departments and health officials in the field. It was a pleasure to work with Patrick on this. I think that, Florida is just like an excellent example of, how good, quality, costs, and other data can be used to facilitate this kind of collaboration between practitioners and researchers. And so, I'd love to work more on this. And so I'm glad, both of you were able to join the call today and provide your perspective.
All right, thank you, Simona. So we're going to open the questions now to the audience, and you can either type your questions in the lower right chat box, or you can also just introduce yourself over the phone as you ask the question. But let's start with some of the questions that have already been typed out in the lower chat box. And this question, of course, is not only for Simona, but the two guest speakers can also chime in as well. So there's a question from Julia. Do fees for regulatory functions such as food service inspections come back to the health department in Florida? In other words, does an increase in service volume have the potential to generate additional revenue?
This is Bob. The answer is yes. Each of the county health departments perform their own inspections. We have our own fee schedule, which is a combination of statewide fees, and our local county commissioners can add additional what we call county fees to help the revenues of the environmental health match the expenses. So yeah, that is the case.
No, Bob, this is Patrick. Bob, so you mentioned something, there's some local autonomy with regard to setting that rate. Is that correct?
Yes, there is.
Okay.
The fee is made up of state fee, which is legislatively agreed to, and county fees, which are specific to each of the 67 counties.
Okay. So in your opinion, do you think that some health districts make more money on this service than others because of those fees? Okay.
Yes, because the county fees vary from county to county.
Right. I mean, just to share my own experience, I've been in states where local politicians kept the fees deliberately low, where the health department was probably losing money on these services. Not Florida, but other states.
All right, thanks, guys. We also have another question from JP. How will the transition in Florida away from local health departments providing Medicaid reimbursable services affect the bottom line of county health agencies? I think that's a question for you, Bob.
In a word, dramatically, and that's what we're working through right now. We have tremendous pressure to make the decision to continue primary care services or to stop them and transition them to federally qualified community health centers, FQHCs, or other agencies in town that'll take those patients. I would say that over half the county health departments over the past year gave up their primary care services in Florida because it was determined that the fee-for-service reimbursement was much lower than the expense of providing those services. And that has led to numerous layoffs in many county health departments. And fortunately, a lot of those laid off employees were subsequently hired by the other entities, but you're going from one state retirement system to a federal system or whatever. So we've been downsizing dramatically across the state because of the transition to Medicaid HMOs. And those who have not closed primary care altogether have chosen to shut down some of their services. Like here in Brevard County, we used to do 5 services: dental, maternity, family planning, adult health, and pediatrics. We gave up pediatrics and adult health this past year, and we're focusing on maternity, family planning, and dental, again, for economies of scale.
Thanks, Bob. We have a question from Cheryl about, were there any changes in TB outcomes with the regionalization of TB nurses and specialists And if, is there any data for that? She recalls a recent outbreak of TB in Jacksonville. Would anyone care to comment on that?
This is Patrick. I mean, the one thing I'll say is this is actually, I think all three of us have kind of mentioned this. This is one of the next things we want to do with this line of research, and we've got to take things a step at a time. But what we want to do now is to start linking the services to outcomes.
And then we have, thank you, Patrick. And then we have a question from Sergey related to the model. Are there any plans to incorporate factor prices or wages into your model, or maybe use fixed effects to account for the unobservables?
Yeah, this is Simone. As far as I know, and Patrick, correct me if I'm wrong, we didn't have wages available to us as part of the data we had, and maybe I'm wrong, but what I saw is that we didn't have it, so we could not incorporate that. But it's certainly a great idea. We didn't use fixed effects at this point, but yeah, I think as we plan to extend our research toward more years, that's certainly something we'll look again into. At this point, we only had the 2 years, so we didn't do it, but yeah, it's something that I think will make sense for a longer panel. So thanks for those suggestions.
Right. Yes, Simone, thank you. Right. We could bring things in like the Medicare wage index. But one of the other things we can do, and this is something we had looked at earlier, but again, it's just having limited resources. Florida has a fantastic data set, and we know the actual staffing mix by local health districts. So we could look at that staffing mix, the level of people staffing those, the level of people going into those FTEs, and the average salaries, and we can look at, we can bring that into future analysis to start doing more fine-tuning. In other words, not just how many people, but what mix of people going into service production seems to be most efficient.
Thank you, Simona. Thank you, Patrick. I think there was a comment about, I guess, your results for your scope, economies of scope services regarding the interchangeability of your service delivery personnel. I think it's in the chat box. I don't know if you see that, Simona. Would you like to care to comment on it?
Yeah, so I'm not sure I completely understand it, but I mean, I think it gets to the point that, yes, we did study 5 quite different services, right? So they are core services, but they are not necessarily closely related. And also, I think it may get a little bit to the point of, what I was trying to make when I explained the measure or the indicators we use. So we look at the cost of providing a certain service, right, like a certain, let's say food hygiene services. But our scope measure really is a very broad indicator of at the health department level, right, using the nature profile survey. So we use those indicators because that's what's been used in the literature. So there's a number of studies that have actually used exactly the same definition. So we wanted to be consistent that way. But I agree there are limits to this measure, and if we were able to define scope differently, and I think the question may get to this in terms of trying to not look at overall scope, but look at scope in a more narrowly defined area. I think that may give us different results. So yeah, it may be something we could look into in a future study if we actually looked at related services and sort of tried to come up with sort of Florida specific scope measures. So it's a great idea and a great comment. Thank you.
Hi, this is Patrick. And speaking of economies of scale, I think I had mentioned it, but I'll remind whoever asked the question, I did invite others to please help us look at all the other services. There's a lot of them, and we need some help. And speaking of economies of scale, a lot of this I've already got it in wiki form, formalized the data dictionary. That was, in terms of, as an economist, that's a lot of, that's a lot of upfront effort. And the more people who use this to study this, the less the cost per service for me. So I'm trying to get those economies of scale from setting up the wiki and the data sets. So please, if you're interested, let me know, and we can let you help us find the answers here.
Well, thank you, Patrick. And I think we've got 5 minutes left in the webinar. And I guess to wrap it up, I'd just like to ask Simona, I mean, what are your plans moving forward in using these results? Have there been opportunities? I mean, of course, it's been the obvious path of publications, but has there been opportunities for these results to be used, to inform practice?
Well, I think we're working on disseminating these findings. As I shared, we did have two sort of short reports, brief reports out in Frontiers. I think the paper that's coming out next year, I think, is sort of what I presented today. Hopefully, and will be available to a broader audience. I mean, we have been presenting this work at numerous conferences as well, and I'm glad that with Robert, we have someone, involved who is actually, working with, financial managers, administrators in health departments. So yeah, but I agree. I mean, definitely, I think now that we have, these models finalized, we have some interesting results. The next step will be to try to disseminate this a little bit more, and maybe at least encourage discussion of some of, the potential implications. I do work currently on some of the DAX studies, so I do some of this work in different states, and I know there's interest really across the country in some of these findings and this work. And I do hope that Patrick and I and others who are interested can continue this work, especially, and I think both Patrick and Robert mentioned this before, we do want to see eventually the link with outcomes. So we do want to understand, whether spending and then the cost and efficiency service provision, how that affects outcomes, how it can make a difference. And so hopefully in the future we'll get a chance to study that.
Fantastic. Thank you so much, Simone, for the time and presenting your research today. And also thank you to our guest commentators, Patrick Burnett and Robert Vito. If you want to get in touch with them, their contacts, or you can also go through Ann Kelly here at the National Coring Center. So we're really grateful for the presentations today. Excellent presentation. And just to keep everyone informed, we would like to invite you again on October 29 for another presentation as part of our webinar series. We have the response willingness among public health workforce and emergency preparedness laws. Our speaker will be Daniel Barnett from Johns Hopkins Bloomberg School of Public Health. So please also refer to our website for future presentations also coming up. And if you have any questions, please get in touch with Ann Kelly here at the National Coring Center for PHSSR. So we thank you again, everyone, for joining us here, and we hope you have a great day, great afternoon. Thank you very much.